Afternoon, everybody. My name's Leanne Wells. I'm the Chief Executive of the Consumers Health Forum. You're here today listening into one of our CHF Talks webinars. And today we're going to be talking about the really important topic of patients as partners in care. I'll introduce our very expert panellists in a moment, but first I'd like to start with acknowledging the traditional custodians on whose land we're all meeting today. And for me, because we're all around the country, for me, that's the Ngunnawal people here in Canberra. I'd like to acknowledge their elders, past, present, and emerging. So the context for this webinar, we have a 10-year primary healthcare plan in development here in Australia. And I think it's also fair to say that with the COVID pandemic, we have seen, I suppose, the primacy of primary care and how important it is as a care setting, not only for COVID testing, but also for it's just the setting where people in pandemic crises need to go to continue to maintain and manage their health care. So the primacy of primary health care is very, very important. We're very excited about the development of a 10-year primary healthcare plan. And often when we think about primary care plans, we think about general practice and the settings in which primary care are delivered. And fairly typically, I think it's fair to say the conversations often run to how services are configured and how services are funded, the bottom line. But more fundamentally, what really matters, we think, is have we got a primary healthcare system geared around people, geared around patients? That's the very first question we need to be asking. It's a first order question. So this webinar will discuss how we can ensure and what sorts of programs, what sorts of tools, what sort of systems, what sort of patient enabling strategies do we need to be thinking about in the primary healthcare setting to truly make primary healthcare practice the principles of patients as partners in care. We've got big drivers in the hospital system here in Australia. We've got a mandatory standard 2 under our hospital and community services standards frameworks that make that mandatory. It's less so. I mean, there's certainly guidelines around working with patients through college GP guidelines and those sorts of things, but it's perhaps not quite so systemic. So a really important topic. I'd like to now introduce our panellists, and we're very delighted to have with us, and I'll introduce them all as a block because then we'll roll on and allow each of them to follow the other as they talk. So we've got 4 panellists, 2 of our foursome, Associate Professor Larry Baker from Oregon and Professor Michael Greco from Brisbane, have worked together in Australia, the UK and the US over many years, teaching about the importance of patient activation, of listening to patients in such a way as to encourage a partnership for the mutual benefit of both the patient and the clinician. They're joined by another innovative practitioner and advocate for primary healthcare reform, Adjunct Professor Paresh Dawda. And importantly, we have health consumer advocate Linda Beaver, a long-time friend of CHF and fierce patient advocate, I might say, an effective advocate who's been a clinician and an educator and a manager of health education departments and a developer of continuing professional development in addition to her consumer advocacy hat. So welcome to you all. The format for the webinar is we're going to have presentations, short presentations, fairly short, snappy, from all of our panellists. We've got about 25 minutes for questions. I'd invite you to put questions or comments into the Q&A box, and we'll also run through some of the questions for our panellists in the Q&A session that we received from participants prior to this webinar. So we've got lots of meaty issues to talk about. So without any further introductions, Linda, over to you.
Thank you very much. I'm going to share my screen now as I start this brief presentation. Thanks for giving me the opportunity to be here today. I'm talking about health communication and the two-way street that we really need to be thinking about. This slide starts the process by really addressing both sides of the equation in communication, both from the clinical perspective and also from the health consumer perspective. So often we're fronted with the, I'm your expert, I'm your clinician, I'm here to give you the advice and direction and support that you need. I'm really there to encourage and get this sorted for you. Are you listening to what I'm saying? Are you able to take this on board? And are you going to be able to comply and work with me to get the best results? On the other side of the coin, we've got the health consumer who would be saying, look, I'm trying to tell you I've got a problem. I don't know what's going on. I've got other things going on in my life. I really need you to listen to me. You need to look at me. You need to pay attention to what I'm saying to you. Are you really listening? And this can be one of the issues we encounter in this fairly simple approach to health communication. One of the main things that we need to consider in this area is not only the fact that we've got a whole lot of the community that really do not have an adequate understanding of health communication. They don't understand health information. You can be really highly educated, but you won't essentially understand the itises and the ologies and the abbreviations and the jargon that we all use and we refer to and is so common in the health industry. We need to move on from that. And most importantly, we need to take the opportunity to permit health consumers to be active participants. For years, I've been involved in seminars and workshops and programs where we talk about health literacy and the issues associated with that. We talk about person-centered care and all the ideal models associated with it. But what we haven't done well is actually give that person sitting in the waiting room, trying to get over their anxiety about their health issue, permission to ask questions. We haven't empowered the consumer to say, look, I don't understand it. I can't do this. What do you want me to do? How can you understand what I need if you won't listen to me? We haven't given that permission. And we certainly haven't, in my opinion, provided the skills required to enable health consumers to take this on board. We really need to get people a little more educated in what those realistic expectations could be to enable them to be responsible, respected participants in their healthcare conversation. The prompts are the things that the healthcare provider can take control of. That looking, that listening, that interacting, that reading the cues, that trying to understand the issues that individual may be encountering is also terribly, terribly important. The body language, the way in which that individual is responding to questions, and clearly getting over that, okay, thanks very much, we've got this, so any questions now? Because that just doesn't work in this situation. So we've got permission. We need to train people to develop the skills and the confidence, but also encourage our health practitioners to be proactive in reading, looking, listening, interacting, and being more adept at facing the challenges that that person sitting across the desk or the room might be encountering, and work with them to try and achieve more positive results. I encourage people across all areas to look at the ways in which they are able to participate in this particular element of their care. There are lots of things, and unfortunately my slide just skipped over two, but I'll talk to the previous one. It's about preparation. It's about giving the opportunity for people to know what to go to a consultation with and know how to anticipate that process. So one of the things I've done over the years is try and encourage people to be prepared, to have a list of the questions they want to ask, to know why they're actually going to see their healthcare practitioner. It enables them to be more confident, because this can be a time of great uncertainty, and great anxiety can build around the unknown elements of their healthcare issue. If that person is also enabled to be prepared to say no or to ask questions, it makes a difference. And this is where my rule of fives comes to play. Over the years, I've looked at this and thought, wow, there's some simple questions that we could be providing for our healthcare consumers to help develop this two-way communication pathway. The rule of fives about pain. Know what your pain is all about. Write down when your pain occurs, how you manage it, etc. The same with medications. Enable that person to be able to ask some simple questions about the medication issues they might be encountering. What to ask when you're about to have medication prescribed. How much will it be? Is it a forever medication? Is there something I can do that will make it better for me? And maybe I won't have to take a medication for the rest of my life. And finally, one of the big things is be prepared to ask questions. Ask why you need that referral. Ask what this treatment plan is. Ask what expectations do you get out of the treatment plan that you're suggesting versus what my expectations might be. They can often be two very different things. Communication is so broad-based these days, and everybody has a different way of interacting and responding to communication. So I would really encourage us, when we're talking about two-way communication in the health sector, to look at what we can do to provide things in a way that enables everybody to get the best opportunity for their benefit. And finally, a phrase we use in scouting all the time: tell me and I'll forget, teach me and I may remember, but involve me and I will learn. This could well apply to health communication, engagement and connection. Thank you.
Thanks very much, Linda. What an apt sign-off message there. Involve me and I'll learn. Thanks again. Michael, over to you.
Thank you, Leanne, and welcome all our viewers. I wanted to pick up on Linda's point about partnership. I'll be really focusing on measuring, I guess, that partnership with the patient activation measure, which is obviously about activation. My colleague, Professor Larry Baker, will speak after me about how we can better walk alongside a patient's journey of healthcare in that context of partnership. So the patient activation, I'm sure many of our listeners, viewers would have heard about it. It's simply a patient's willingness, as you can see there, to take independent actions to manage their care. And it comprises of their knowledge, skills and confidence, something that's built within us. And we know that typically in a population, about 40 to 50% of patients with complex and chronic conditions have lower levels of activation. How is it measured? You know, how is this done? Well, it's a simple 10-item questionnaire that gets more difficult to answer. And by answering the questionnaire, we're able to generate a score, and that score is 0 to 100, and it's an interval scale score. I won't go into the background of how that's done, but it is an interval scale score, an empirically derived score, just like taking someone's blood pressure or their blood sugar levels or weight. These are all interval scales. And what it produces is a score, 0 to 100, but also we're able to produce a level, levels 1 to 4, level 1 being a lower activated patient, level 4 being higher activated. And what that does is it enables us to do a few things. One is to look at population risk stratification. For example, as I said before, about 40% to 45% of the population would be lower activated, and the rest would be more highly activated. But we need to know where patients are on that journey. And it's a single point change that we are interested in as well, because that has significance in terms of value based care. The PAM is really about predicting patients' behaviours in terms of the way they use healthcare. So we know its links to unnecessarily hospital admissions and readmissions and care experience and medications as well. And this prediction means that a 1-point score change in a person's PAM scores actually has significance. You can see there on the slide some of the studies that have been done. But in general, we know that the lower level activated patients will move about, if they move 1 point, that equates to about a 3% improvement in health outcomes and about a 3% reduction in resource utilisation, like unnecessary hospitalisations. For example, you can see here on this slide, this is PAM predicting unnecessary hospitalisations. And you'll see that a lower level activated patient, PAM level 1, is 62% more likely to have an unnecessary hospitalisation compared to a higher activated patient, a level 4 patient. Similarly, the prediction of a future chronic condition diagnosis. You'll see in this work that was done in September 2016 that a lower level activated patient is 51% more likely to have a new chronic condition diagnosis 2 years later compared to a higher activated patient. So this is sort of highlighting the predictive value of PAM. In fact, there was some recent work done in the UK, and this was a cohort of about 10,000 patients, where they found that they could improve level, not just the scores, 1 point, but move patients from level 1 to level 2, so from a very low activated patient to moving along that continuum. They would prevent about 333,000 ED admissions and 504,000 A&E attendances. That's phenomenal figures, just by helping people to be more activated. So it's important to realise that self-management behaviours vary significantly by activation level. The way I engage in my healthcare will be dependent on how activated I am, whether I exercise, take treatments as recommended, or do preventative health screening. That will depend a lot on my activation level. And the good news is that we can shift activation. That's really important. And it's the partnership approach that Linda talked about that helps the lower activated patients, more so than medical interventions in a sense, to move people along activation. Larry will talk more about that as soon as I finish. And this brings me to my last slide, which is around some work done on over 1 million patients, 184 organisations across the world using patient activation and trying to improve. And these were patients that had been given the questionnaire twice, baseline and within 6 months, over 1 million people. And they found that through various interventions, they could move typically lower activated patients almost 10 points, which if you think about it, equates to about a 30% reduction, improvement in health outcomes and reduction in resource utilisation. It gets more difficult to move people as they're more activated. And the level 4s, you might think, well, they've gone backwards, they're -4. That actually, they don't dip from level 4 to level 3. Their scores may decrease just because it's harder to maintain that higher activation level. Some of the examples of interventions I'll finish up on were things like health coaching, social care interventions, whether they be housing for for people in need, and clinician communication skills. And that's a good segue to pass on to my colleague, Professor Larry Baker. Thank you.
And just while we hand to Larry, I might, we will take a lot of questions when we get to Q&A, but there's just a couple here in the Q&A that I might draw to your attention, Larry, because you might be able to cover it off in your presentation if you don't already. There's a question about, is there an equivalent tool to PAM for measuring clinicians' activation in terms of attitudes to towards listening and engaging and empowering patients? So that's one part. And then there's another question here. Can digital health help measure patient activation, partnership, health and well-being benefits of activation? So just something you and Michael might want to comment on either in your presentation or later. Thanks. Over to you, Larry.
Great. Thanks, Leanne. I've unmuted, so I think you can all hear me. That's a good thing. Let me get my slides up on the screen, and then we can, there we go. Oop. Right. Are you seeing the slides all right? I got to share these. That's what I got to do. There we go. So what I wanted to do is to, let me get back to my slides just a second here for you. Stop sharing for a second. Get back to my, here we go.
While we're waiting, Michael, did you want to make a comment on those two questions about the equivalent tool?
Yeah, look, while Larry's finding that, there is a clinician PAM looking at how willing they are to activate patients. And there's been some work and published on that around the clinician PAM. Some of the research showed that in terms of predicting a patient's activation level, clinicians only got it half right if they took a guess, a bit like trying to guess someone's blood pressure, I guess. They got it half right, but 100% of them were convinced that they were confident that they got it right. So it's important to measure someone's activation level.
Good. So,
you good to go, Larry?
I think I'm good to go. You can see my slides now? Good.
Yes.
Okay. What I wanted to do is give you just a very quick snapshot about things that clinicians can do, doctors and other clinical folks who take care of patients, especially those who are living with chronic disease, to help them on this journey. And it starts with listening. And I hearken back to when Michael and I were teaching this in a series of trainings that we developed in the UK for the National Health Service. And as we started to incorporate this notion of patient activation, clinicians came up to us afterwards and said, my goodness, some of them were aware of what Michael said. I wish I could understand this. Oftentimes when I ask patients, how ready are you to really work on your healthcare? They all said yes, but then they'd come in a month later and many were still in these early stages struggling. They wanted to please. So when we told them there was an instrument, they said, that's fantastic. Because if I know where my patient is on this journey, it's a way for me to hear their voice. Just like when I put on my stethoscope and I can hear their heart, now I can hear where they are on this level of activation, on activation, this journey of taking care of themselves with a chronic condition. And then I can adjust so that I'm walking alongside them. I'm not racing ahead thinking, oh, they're all ready to just learn all the science of diabetes and all this stuff when it's early days for them. I have a different role I need to play for them. And so by this notion, we call it walking alongside. If you listen to the patient, either through an instrument or some other way, to know where they are on the journey of activation, first of all, the patient experiences being heard by their clinician, which is powerful. And for both the clinician and the patient, these consultations become less stressful because they're walking together, not one's racing ahead of the other. And that patients will, as Michael pointed out, with these kind of interventions, patients can move on that journey more rapidly to higher levels of activation, which of course will lead to better health outcomes, better health behaviors, those things that are going to be better for the patient. And for the clinicians, I think one of the most heartwarming things for us is that they said, you know, this gets me back to where I wanted to be. This is why I became a doctor. So I could be with my patients in this kind of congruity. And for them, it returned the joy of clinical practice to them. So we can think of the clinician-patient relationship as really made up of multiple roles that the clinician has with the patient. Of course, there's the role of scientist. They have knowledge, tools, all these sorts of things that they can bring to bear to help the patient on their journey of health. But there are also more relationship kinds of things about being a trusted companion, being a celebrator of success, being a coach, being a collaborator that when applied at the right time, or emphasized, I should say, at the right time, can be quite helpful to the patient in their journey. So let's look at that patient who is level 1, where Michael described them earlier. The key here, among many other things, but really emphasize building trust. What do we mean by trust? The good thing is in Australia, the United States, and other health systems, certainly in the industrial world for the most part, patients believe that most of their clinicians have the knowledge, the skills, the tools, the ability to understand their disease and get them the best treatment possible. This is a different kind of trust, something that's a little more primal, really that sense of this person is going to be a companion with me on this journey of my health. I'm not always going to be so healthy. I'm not always going to be so good at being a patient, but this person's going to be with me. They're a trusted companion. And we'll talk about ways that you can imbue that in your relationship very quickly as a clinician. In addition, it's an opportunity as that trust builds to start helping the patient develop more awareness of what it is, what this means to be on this journey, to live with the long-term condition where you have to take care of yourself. It's not just take the tablets for a week and you feel better. It's a journey. And to begin to be interested in bringing more knowledge about that journey. Level 2, it's an opportunity to focus a bit more on being the celebrator, continue to build trust, but now the patient is interested in making some small changes. They're not very confident about it, but when they do have any kind of small change at all, celebrate that success. Help them feel more confidence to be on this journey. Level 3 is about being a coach. It's about now you're really in there helping patients select new behaviors, reinforcing success, building some problem solving. Finally, at level 4, it's about being that collaborator in the journey now. Really, the patient brings so much to that consultation and to their health, because they are. And here we're beginning to co-create consultations, really getting the patient's input about what the agenda for that consultation will be. So we made up these 4 tables, lots of information here. You're getting lucky. I'm not going to talk about all of them today, but I just want to point out a few techniques. Here, building trust. Trust, it turns out, so much is built in that opening minute, really from the first moment that the patient sees the clinician at each consultation. And so one of the things that a number of our colleagues have adopted is actually taking a moment, even creating some what we call words of hope, words almost like a little mantra that prepare them to go out and to engage that patient, to be that trusted companion on the journey in a day when there could be chaotic and all kinds of other challenges are going on in their lives. A pediatrician who realized that he was often the patient's first doctor and knew that oftentimes they'd be going on to a different doctor as they became adults, made up this words of hope he'd say before each consultation, before he went out to see the patient. He said, want to see me, gonna miss me. And that's his way of tuning himself up to be ready to engage that patient. So here, level 2, we want to be the celebrator. We want to celebrate success. And we encourage, for example, to begin each consultation pretty early on with asking the question, tell me something that you're doing to take care of your health that you're quite pleased with. And just be ready to hear the patient tell you how they're doing something about their health that they feel is successful. They may not be doing everything they need to do, but you want to celebrate those moments of success. And then with patients at level 3, here it's the more typical coaching. You're going to help them create action plans, make sure it's one that they can succeed with, so on and so forth. Finally, at level 4, and at other levels too, when it's appropriate, you really want to start collaborating with the patient on the agenda of each consultation. One of my colleagues taught me this years ago, and it's so valuable. Ask each patient early on in the consultation, what's the key thing you want to make sure happens before you leave here today? To really understand what they want to achieve in their visit. That's a very quick run through a number of techniques, and I'll hand it back to you, Leanne.
Thanks, Larry. We'll go to Paresh now, and then to open Q&A. Over to you, Paresh.
Thank you, Leanne. Thank you for those wonderful presentations. I shall just do a screen share and we'll just start the slideshow. So thank you all, and thank you for the opportunity to be here and present to you. So really what I'd like to do over the next few minutes is talk about an authentic partnership for person-centered care. I guess that starts with what is person-centered care. And Michael mentioned the Health Foundation in the UK. The same organisation published a paper on what person-centered care is, which I really quite like because it's fairly simple, it's easy to relate to. And essentially they said it's about personalised care, so individualising care based on what matters to that person. It's about coordinated care, joining up the dots and integrating. It's about enabling, and I think the conversations we've had from Linda, Michael and Larry, they're all around patient activation. They're actually about enabling, they're about consumer enablement. And the final aspect is the relational aspect of care. It's about being respected, treating with dignity and compassion. And all those four things come together really to give us person-centered care. So how do we do that in an authentic way? I guess a prelude to this presentation, to this whole webinar, as Leanne said at the beginning, is the 10-year primary healthcare strategy that's in development. And you know, 10 years, a reasonably long time frame. So I thought, let's think about what the future organizational needs are. And I came across this blog from McKinsey's last week, and they were talking really about the future of organizations in general, particularly in light of the experience from the pandemic. And really they talked about three things. It's about who are we, and being really clear about who we are and having a shared purpose with a value stream that matches. It's about how do we operate, and then it's about how do we grow and continue to improve. In the few minutes we have, I'm going to really focus on the how do we operate, and really sort of thinking about the future. I guess there's three high-level things that come to mind. We often think about healthcare as a service industry, don't we? I'd like to actually challenge that and say we shouldn't think of ourselves as a service industry. We should think of ourselves as an experience industry. People access healthcare, and what they're left with is the experience. And we should really be focused on that experience and optimizing that and the outcomes that follow from that. You know, I think the future of healthcare is going to be as much about care outside of the practice and the bricks and mortar as it is about inside the practice. So let's just keep that in mind and think about that. And with the changing demographics, the multimorbidity, increasing complexity, it's going to be about team-based care and enabling that through technology. So they're just some high-level thoughts. So let me take you through a journey, and let's together maybe imagine what a future organization might look like. Let's start with the bricks and mortar, and let's start with the waiting room. Why do we have a waiting room that's called a waiting room? Should it not be a living room? Should, as patients, we not feel as comfortable in a room waiting to see a clinician as we do in our own homes? So let's think about the waiting room as a living room. What if in this living room there was music that was perfectly curated at a tempo of 60 beats per minute that we know is the most relaxing and calming before we go and see the clinician. What if this time in this living room was spent in such a way that we were supporting and enabling some of what Linda was saying, giving people the opportunity to get their thoughts out there. Maybe doing something like a PAM score through a tablet device. What if in this living room we didn't have receptionists, but we had patient advocates who were there to support patients, to take them through this technology-enabled touch point in the living room, where they could complete a PAM score, they could complete some other patient-reported measure, they could put in why they're there. What if we just reimagine that front of house experience within the practice? And then, of course, we've got the consultation and we go into the clinician's room. What if we just thought about the setup of that clinician's room? So we didn't have the square desks, we had the round desks. So we're all around the table in a collaboration, in a partnership. What if this room had two doors, one for the patient to come in, and this room was the patient's room for the entirety of their presence at the practice, and the rest of the team members came in and out of a second door, the team door, so the patient doesn't have to move around, but it's the team that's moving around them to make it person-centered. What if we did what Linda was talking about, build the education, build the health literacy, what Larry was talking about, using some of those techniques, and shared them, perhaps through a big screen. We could share the electronic health record on here so patients could see exactly what we're writing about them or what we received about them. We could maybe share education material on here so so we can help support and enable in the way Larry was talking about. What if we had the ability to put whatever education material we used here onto an app which every patient had? So when they went away and they think, oh God, what did Dr. Dawda tell me about my high blood pressure or about my diet? They just go onto their app and that same material is there. What if this app allowed them to contact the practice through secure messaging, through video conferencing? What if we actually took this app further? And what if this app, in their doctor's voice, said, Mrs. Smith, you've got your appointment with the cardiologist next week. Don't forget to have your blood test this week before you see the cardiologist. Or Mrs. Smith, you've forgotten to take your morning medication. How powerful would that be in their own doctor's voice to support that enablement, to support that patient activation Larry was talking about? Now, remember I said one of these sort of high-level thoughts around the future is as much care happens outside of the practice as it does inside the practice, and the whole concept around team-based care. What if we had a practice that had a team collaboration area? And I call it the Schwartz room, and I'll explain why I call it the Schwartz room in a moment. But what if this collaboration area was the space where team members could talk, have conversations about patients, do those handovers as they're moving in and out of the consulting room. As I mentioned sort of earlier, what if in this team collaboration area, we had a big screen and we were able to remotely monitor people with chronic conditions in their own homes? Maybe we could video conference if we see one of the parameters beginning to go off track, all from this team area. Why do I call it the Schwartz room? Because this is the sort of team area, and Ken Schwartz was a health attorney in Boston in the 90s who was suffering from lung cancer. And just before he died, he set up the Schwartz Center. And this is a quote from Ken Schwartz where he says, I've learned that medicine is not merely about performing tests or surgeries or administering drugs. For as skilled and knowledgeable as my caregivers are, what matters most is that they have empathized with me in a way that gives me hope and makes me feel like a human being, not just an illness. It's the small acts of kindness that make the unbearable bearable. Stemming from Schwartz Center are things called Schwartz rounds, which are about allowing team members to have conversations and really put them in touch with and remind them about the compassion, about the dignity, about the respect, about the empathy, which is that fourth component of person-centered care. When we come, when we think about this, it's about people at the end of the day. It's about the young, it's about the old, it's about the diversity that we see. I took you through that journey of a future practice. One of the things I learned is, that the future's here now. So whilst I painted that as a story of the future practice, it's not actually a future practice. It's a practice we're opening in 2 months' time in Canberra. So these things can happen, they can happen now. We don't need to wait 10 years. The importance, I guess, is how do we, in that 10-year strategy, allow this to happen so it can happen at scale, consistently, in a standardized way, across the board, and support that growth that we want in future organizations. And with that, I'll just stop and hand over back to Leanne. Thank you very much.
Thank you, Paresh, and thank you to all of you for those very deep and rich insights and comments. I'm going to go to questions now. I'm assuming our panel can also track some of we've got questions in the Q&A box as well as comments. I might just pull out a few questions that I want to put to you as a panel. But perhaps a nice segue to this question from Bridget, Paresh, from your presentation. You've spoken about what if and the future is now. Bridget says, this seems like a lovely ideal, but has much work being done looking at barriers and facilitators to PAM becoming more widely used. It appears to me the age of 15-minute appointments and perhaps seeing a patient only once, that time may be a major barrier.
Thanks, Leanne, and thank you for the question. And I guess my comment at the end around, the future to 10-year primary care plan really needs to think about how this can be enabled and supported. Yes, I think it's a very valid point. I think the overall premise that I sort of said at the beginning is this is about the team and it's about technology enabling. So, let's allow everyone to work at the top of their license. In the model I was describing, the patient advocate would support some of those components even before you got to the to see the doctor or the clinician. The digital enablement, so the use of apps, for example, where people are able to use them. And I recognize, we may have a question around, does that create an equity or an inequity in the system? And we'll come back to that if people want. But, the touch points with your healthcare provider don't need to be restricted to the 15 minutes. They can go beyond the 15 minutes through using team members and through using technology. And I think that's how we make it happen.
And that's a behaviour change management challenge, isn't it?
Absolutely.
Yeah. Comment here, and I'd like your comments on this too, particularly, there's obviously a health literacy dimension to all of this as well. And there's, in the same way we've got variation in patient activation, there's variation in the degrees of health literacy, as we know. But a comment from Chris here, we could be better prepared. So to Linda's points about the rule of fives, We could be better prepared for appointments if we had access to our pathology, radiology reports prior to meeting, copy to patient where there is agreement to do so, so that we can shape the questions we want to ask and identify aspects of the reports we would like to better understand.
So would you like me to comment on that, Leanne? Or?
Please, Paresh, and Linda, you might want to comment on that too from your perspective as a consumer advocate.
And look, I totally share that sentiment. Again, I think through the use of technology, through electronic medical records, you know, why do we have artificial barriers in place preventing people from being able to access their own records? So, you know, there's big movements in the US and the UK and New Zealand around patient portals. We've of course got My Health Record, which perhaps is slightly different to the patient portals we've seen in the other countries. I absolutely agree, and this is a good reason. I think the default should be every patient should be able to access all those things that were mentioned, unless there's good reason not to. So it's that sort of opt-in rather than opt-out sort of principle.
Linda, do you have any reactions to that comment from Chris?
Yes, I think it's really important to have transparency in some of the information about our health. There's no doubt about it. But what does it actually mean? So as a health consumer, having, you know, reports sent to us doesn't always have any great meaning. But if there is a way that that information is translated into very user-friendly dialogue and words, then that starts to take on a whole new dimension. And rather than getting a copy of the pathology report that's got, you know, the normal parameters, understanding perhaps that, you know, that result means that this has happened and this means we need to do this to help sort it out. That's a very realistic way of enabling a consumer to be a little more informed about what's going on and allow that better preparation. But I guess the problem then is who's going to be able to take the result, transcribe it, if you like, into user-friendly language, and then forward it to the individual concerned. That's a part of process that I think, you know, is something we can look at in the health system if it's going to make a difference.
Thanks, Linda. Paresh, you used the expression before, which really resonated with me, that we need to change the thinking in healthcare for the healthcare to be thinking less of itself as a service industry and more of itself as an experience industry. There's a comment here from Rita, or a question actually from Rita. How might we develop the systems in primary care to implement patient activation measurement? And I think the broader, how do we develop the systems in primary care to implement and create a culture such that measurement of patient activation, but also measurement of patient experience and how that can be fed back into service improvement, improved patient communication, those sorts of things. How do we bring about that sort of culture on a systemic level? It you know, happens in pockets, it seems to me. Michael and Larry, did you want to comment on that?
Yeah, thanks. Yeah, look, I think it's got to be a win-win in a sense. I know, you know, I'm you know, all for and Mr. Patient-centric. It also, it's not at the expense of teams working with patients. I think that if we can embed these in a way, and just going back to the enablement that Paresh and you talked about, you know, that enablement has to be tailored as well, in the sense that some people just won't resonate with results, or, you know, they're not at that stage of the journey of self-care, self-management, and that's why we need to measure. So how can we build that into the system? I think clinical teams have to see the value of measurement. We don't want to measure just for the sake of measuring. And I think, you know, patient activation is one of those measures where, as Larry mentioned earlier, and Larry, feel free to chip in, where they can see that sometimes the clinical indicators don't change as quickly as the patient activation measure score changes. So they can see success you know, we're working with, Mrs. Jones, and we can see she's moved from this score to this score, can be very encouraging for a clinical team. And be able to sort of say, well, she's at level 2, she's got COPD, respiratory issues, we're going to work with her this way. That can be quite sort of empowering for the clinical team, as well as for the patient, because they feel like the team is on their side, that walk alongside that Larry talked about. Larry, do you want to add anything there?
Well, I think, Michael, you've really hit on something that's really important. It's got to be a win-win. It's got to be a value for all parties involved. And I think one of the pleasures that you and I have had is as we help clinicians to learn how to tailor consultations to better walk alongside patients, they like their practice a lot less and a lot more, and they're feeling a lot less stressed. So I think through that experience, and certainly that's the work that I'm still dedicated to doing, I think there's it's a what they call it, a virtuous cycle. As we start this off and we can reinforce it and provide resources to do it, all parties involved get benefit from it. So I'm optimistic.
Yeah, and I think, Leanne, the question about how do you build it into systems, I mean, it reminded me a bit about patient-reported measures, PRAMs and PROMs. Patient activation is like a gold standard PROM in a sense. It's an outcome measure, but PRAMs is, I love that what Paresh said about the the service industry, but an experience industry. So PRAMs fit really nicely there. So I know some of the states, particularly New South Wales, are looking at a statewide PRAMs and PROMs solutions. And other states, I'm sure, are looking at it. I think Queensland is another state looking at it. I'm not sure what other states are doing, but I think the more we have those in the system, and that's the patient as teacher then, isn't it? The patient as teacher, which is, I think, and that's partnership. Partnership is both sides. It's not a one-way process. So I'm encouraged about what I'm seeing happening in the Australian healthcare system in terms of where we can get to. Yeah.
Thanks. And we've been talking about these sorts of issues: health literacy, patient self-management, patient activation, self-care in the primary healthcare setting. Primary healthcare is all about managing multi-morbidity, complex morbidity, increasingly so these days. There's a question here about can patient activation also be successful, from Kay? The question's from, can it also be successful with mental health patients? These patients can be unresponsive due to their mental health issues.
Oh, look, absolutely. There's been so much work done, probably more work done in the mental health area with the patient activation measure than any other condition. So yeah, look, the answer is just a big yes. There's literally hundreds of publications around this area. And look, in terms of conditions, patient activation measure is across all conditions. Because as I said earlier, it's something that we have within us, our knowledge, skills and confidence in self-care, whether we consider it important, whether we have the confidence to do anything about it. These are things that in a partnership approach, clinical teams and providers can help a patient on that journey, whether it be with mental health or with other life sort of conditions. Yeah.
Thanks.
Let me just add, Michael, that when we were working on the Co-Creating Health project in the UK, there were 4 main conditions in which all this training and interventions were tested under. One of them was mental health. And I can certainly say my role was mostly working with clinicians, but they were very receptive to learning ways to work more in partnership with their patients. And in fact, the skills that we were able to teach them, like some of the things that we showed in our slides today, were very well received and seemed to work well with patients. So I'd like to answer Kay's question and say yes. Walking alongside a patient, whether their condition is chronic obstructive pulmonary disease or whether it's depression, it seems to have that same good effect, whatever the condition.
Well, thank you. It's heartening to hear those results. I'm going to close with a final question now. And this question is from Kathy. Do you think in the era of patient-centered care, co-design and co-production of services, could health coaching also be done by knowledgeable and skilled patient peer support advocates?
Can I take a crack at that one, Michael?
Yeah.
Again,
we've done that.
Yeah, we've done that, and it's brilliant. I think I'd say it's necessary. I mean, you know, Linda, you kicked us off with that. You've got to have opportunities for people living with long-term conditions to help other people living with long-term conditions, teach them the ropes. There's a lot to learn, and it's not very few of us got that course in primary school. So when we did this in the UK, there was clearly an arm for expert patients teaching other patients, and and I would say it's almost really a requirement that you teach all the parties how to work together.
Well, there was a sort of formalised expert patient program as part of the UK co-creating health initiative, right, wasn't it? Yeah, thank you.
Yeah.
Look, we are up to our last 2 minutes, so I might wrap it up. We have hope you've been tracking some of the comments in the Q&A box. There are some comments there. There are some questions we haven't obviously got to, but we'll do our best to package some answers up to those in consultation with our panelists and get those out to you. But look, there was some really impactful phrases in there from all of our speakers today that really resonated with me, starting with Linda. She talked about permission to ask. Consumers feeling like they've got that permission, that they don't have to seek it, that they've actually got the agency. They are the patient. It's their right to be asking the questions. So she commented on that. We've heard about the role of the patient and the patient as teacher and the notion of an expert patient. And I think the real gem in all of this was, you know, that healthcare is about patient experience as much as it is about getting good health outcomes for people. The two go hand in glove. So that culture mindset reframe around the industry as an experience industry, and really valuing what it is that what experiences matter to patients, is really where we need to be gearing our future policy thinking. So I hope that's been interesting, stimulating for people. We could talk about these topics all day, but I think we've had a great conversation today, and just thank you very much to all our panelists and to all our participants. And the recording for this will be available on the CHF YouTube channel in a little while, not too long for you to wait for that, or for those if you want to share it to your colleagues, and Michael, Larry, Linda and Paresh, if you want to share it for your networks as well. So on behalf of CHF, thank you very much, and we will sign off right on 2 o'clock.
Thank you.
Thanks everyone.
Bye.